antihistamine, and all their receptor sites of their target organs are full of histamine, the Benadryl is going to sit there in your blood because it's got nowhere to go. Okay? So there are insufficient available landing zones for the Benadryl that I'm giving. However, if I have a lot of Benadryl around, a lot of antihistamine around, every time the target organ, whether it's your lung, your skin, your swollen lips, your itchiness, every time they throw off their histamine and get rid of it, I want to occupy that site with my Benadryl. I want to get there. So I'm going to be a competitive inhibitor. That's what that's called. And that's the way Benadryl works. So when I have somebody with an allergic reaction and I give them Benadryl, they may not respond right away. Why not? Because they're all occupied with histamine right now. They're loaded. So, but that doesn't mean I don't want to have that drug available to them. Because I want my drug on their binding site. I don't want their histamine on their binding site. Okay? Then there's a thing called regulating receptor sites. What if I had somebody who had asthma, and I was giving them their albuterol, and they were getting better, but they just weren't responding very well. And I don't know why that is. I mean, why would they respond well enough? And something happened because they called me to begin with, so already they're not responding very well. Most of these people have their own drugs anyway. So one reason they may not be responding is because their beta receptors are not lit up. They're not primed and ready to go. They may have not enough beta receptors. They may have a condition where their beta receptors are what's called downregulated. They're just not as switched on and responsive to their normally occurring sympathetic transmitters, and that's why they get asthma attacks. So if I could give them something that would light up their beta receptors and say, listen, you guys, when you see this albuterol I'm going to give you, get on with it. And that's what some people believe steroids do. So a lot of times when we see a patient who comes to the emergency department that's got asthma, that you guys have given your albuterol neb to, and they're still pretty tight, I can give them more albuterol neb. But I think one of the early things I'm going to do is to give them a dose of methylprednisolone, okay? Because it's believed to upregulate their beta receptors and make them more responsive to the same drugs that we're already using. Plus it's anti-inflammatory, and there's a big inflammatory component of asthma. So we may be able to modify things in different ways. Just a couple other basic things before we wind down. There's a drug-response relationship. You got to get enough drug at the right receptor site to do what it's going to do. And another thing is, what's the onset of action of this drug? What does it do? How long does it take to do its thing? Is it going to act right away, like the morphine I give, or is it going to take a little bit longer to act? How long does it hang around once I've given it? So what's its duration of action? Okay. And then what's its termination of action? When's the level of it going to be so low that it's not going to be doing anything at all? Okay. And we measure that sometimes in what's called a half-life. Okay. A half-life is how long it takes for half the drug to be metabolized and gone. And so if you look at, most people say that if a drug has gone through 4 half-lives, that there's just over 5% of the drug remaining. So that's probably not very effective. Different drugs have different half-lives. Valium, diazepam, has an incredibly long half-life. It has a half-life of about 40 hours. Okay? So that means that Valium lasts a long time, even though you may not feel totally zonked by a dose of Valium. There's pieces of that around for a long period of time. 4 half-lives for Valium is a week. Okay, that's a long time for leftovers. If you've got liver disease, it's going to be around for much longer. Okay, whereas Vicodin has a half-life of about 4 hours. So when you're treating pain management, you know, you're going to have the Vicodin, and about 4 hours from now, that pain's going to be starting to surface again because half that drug is done. So it's just a different order of how we use these things. We talked about a therapeutic index, and we talked about theophylline earlier in terms of its short therapeutic index, okay, very low therapeutic index. Then we have drugs that say, well, it used to work, but it doesn't work so much anymore. That's called being refractory to the drug. I've got somebody who has paroxysmal atrial tachycardia. He used to be able to respond very readily to adenosine, doesn't do that anymore. He doesn't respond to adenosine, he responds to diltiazem. No, he doesn't respond to diltiazem anymore. Now we have him on amiodarone. You know what, he's continuing to go through that. We're going to have to do something else to stop these bouts of this, and so there's another procedure. that might be involved, like cardioablation, laser treatment. There are other response variables. We talked about very young and very old. We talked about weight being a factor in terms of getting enough drug to the right proportion. There are certain drugs that act differentially depending on gender. There are certain conditions in the environment. Seasonal allergies may impact a response to your medicine that you're giving. Timing of the drug. Do I take it before I eat? Do I take it after I eat? Does food interfere with the absorption? What's the general health of my patient? Somebody very frail with crappy circulation, this may not work so well for you like it would for somebody who is more robust. The genetics, and we're starting to look at genetic information to help dose drugs and prescribe specific drugs that have a better efficacy for people with different physiologic makeup. And then there's psychological factors. Are there just getting any kind of therapy makes you feel better, whether it's the right therapy or a placebo, who knows? So just having somebody attend to you, you guys showing up lights and sirens in uniform can have a really good effect on a whole host of dimensions of the patient's well-being. And then we have to look out for bad stuff like side effects. Okay, we talked about antibiotics causing diarrhea, antihistamines causing sedation, opiates causing constipation, it's very common. And so the other thing that we have to expect the unexpected is things that are iatrogenic. Oops, we did that and a bad outcome happened. Someone puts a Foley catheter in someone and 2 days later they have a urinary tract infection. That happens sometimes. We intubated the esophagus. Whoops, that's a big oops. Okay, that can't ever happen. And then there's unpredictable responses, adverse effects that weren't anticipated. Like when my youngest son was 15 and wanted to order something from Apple Computer. And so my wife gave him her credit card and said, you can authorize this purchase for this amount of money. And he did. And then the bill came and there was a shipping charge. So there was an unintended, unpredictable response. Gee, I didn't see that coming, was what he said. But sometimes you give a drug and a patient has an unpredictable response. And that happens too. And so you have to caution your patients about what is likely, and you have to give them a window to be able to get back to you that's saying, this does not feel right to me. And then you listen to them and try to figure it out. We have allergic reactions to certain medications. We have idiosyncratic reactions. One, for example, Bactrim is a very commonly used antibiotic. There's a skin rash that's associated with mucous membrane weeping and lesions that can affect people's eating and swallowing, called Stevens-Johnson syndrome. There's tolerance to a drug. I need more drug to have the same effect. There's cross-tolerance to like drugs. I used to take Ativan and that worked pretty well for me, but now you switch me to Valium and I'm tolerant to Valium. Why is that? Same cousins, okay? They're in the same family. Tachyphylaxis to sympathomimetic drugs. Drug continues to work and it's working more and more and more, and then it just sort of stopped working altogether, okay? I have a decrease in response to a drug dose that used to work just fine. Cumulative effects, stacked up drug dosing. Okay? Repeated administration of a drug could produce effects that are more pronounced than those that were produced by the first dose. Makes sense. Take pain medicine and you stack this drug on top of another on another. Now I have pain relief. Now I have pain relief and somnolence. Now I have pain relief, somnolence, and apnea. Okay, so we're just stacking up doses that way. Habituation, it's a physical and psychological dependence on a drug. Alcohol, you'll have a withdrawal syndrome if you take it away. Alcohol, benzodiazepines, narcotics, those are all things. And we have other unpredictable responses with polypharmacy. We may have drugs that are having additive effects here that are called synergistic effects. Maybe more than additive. The nitroglycerin and Viagra, each one is fine if you take them separately. If you put them together, you're going to have a bigger effect than you would otherwise. So these are all things that you just need to be aware of as we start adding our own materials into the patient's physiology and their own underlying broth that they've got that they're taking. And then I guess last but not least is storage. We have to protect these things. You know, some people park their rigs out in the San Fernando Valley and they bake at 120 degrees for a while, and you don't want to get in it when your epinephrine degrades and it won't work when you choose to use it. So some of this stuff is how we store it for its drug activity and how we use it for our patients. Some of it's how we store it because it's got to be kept secure. Okay, some of these are controlled substances. You don't want these things out there. And you have to control this because the Drug Enforcement Administration will go after you. If you lose some, it has to be accounted for. If you waste some, we have to know that it got wasted. It has to be witnessed. Okay? Otherwise, you're not going to be able to practice. And you won't be able to take care of people, which is why you went to work to begin with. Okay? So the DEA is pretty strict on this. These things have to be locked. They have to be inventoried every day. We have to know how much of morphine we have, how much of our midazolam we have, our controlled substances. When you use it, you have to document it. You have to document that it got replaced. All these things have to be very carefully tracked. There have been cases where paramedics have diverted drugs away from where they should be used, and patients were treated with saline when they thought they were being treated with morphine. These things were tampered with. It's rare. I mean, you know, all of us are entrusted with these things because we are believed to be good stewards of taking care of these medicines so we can take care of sick people. So but these things happen, and that's why these rules are so austere. All right. Think you got a lot to forget?
Yeah.
Try this. This is where I live right now. A lot of time is spent here. Too much time is spent here. Not enough time is spent here, which is probably why too much time is spent over here. All right, I hope we got across the bridge. And as promised, we've made it to the other side without too many errors in judgment, okay? Any last minute questions? This is a huge amount of material. All these definitions, you know, at the end are all in the book. But I think the important pieces are where these drugs come from, how they're derived, how they're tested, how they work, how complicated it is to get them where they need to go and still have them be bioavailable, and how we get rid of them.